Welcome back, everyone. We're going to start our journey through the respiratory system with doing a brief overview of respiratory anatomy and physiology. Let's take a look at some of the competencies you're going to need to be able to perform at for the respiratory system for EMS. We need to be able to integrate assessment findings with principles of epidemiology and pathophysiology to formulate a field impression and then implement a comprehensive treatment plan and disposition plan for patients with a medical complaint. We're going to need to be able to know the anatomy, the signs, symptoms, and management of respiratory emergencies, including those that affect both the upper airway and the lower airway. We're going to need to be able to recognize the anatomy, the physiology, and the pathophysiology, along with the assessment and management of common respiratory diseases, including things like epiglottitis, spontaneous pneumothorax, pulmonary edema, asthma, COPD or chronic obstructive pulmonary disease, and environmental and industrial exposures. We're also going to need to be able to recognize, assess, and treat for toxic gas exposure, pertussis, things like cystic fibrosis and pulmonary emboli, infectious diseases including pneumonia and other viral infectious diseases, obstructive and restrictive diseases, as well as acute upper airway infections, spontaneous pneumothoraces, obstructive or restrictive lung diseases, pulmonary infections, neoplasms, pertussis, and cystic fibrosis. We'll review each of those types of respiratory diseases and discuss the management in subsequent lectures, but let's start out first by taking a look at some of the anatomy and physiology principles, as well as some of the epidemiologic principles for respiratory diseases in EMS. Respiratory diseases are one of the most common pathologic conditions and probably the most common EMS complaint in most services. In fact, a large majority of medical complaints that we see within EMS have a respiratory, are either respiratory in nature or have a respiratory component to them. Asthma and COPD is the abbreviation or acronym for chronic obstructive pulmonary disease, are among the top 10 chronic conditions causing restriction on an individual's activity basis. In other words, these are one of the top 10 chronic conditions that prevent a person from living a full and active lifestyle. Pneumonia is one of the most common fatal illnesses, particularly in developing countries. And you can see here a table that breaks down some of those most common respiratory diseases in our population. When we talk about anatomy and physiology, one thing that helps is association. And so you can think about the respiratory system, at least the lungs portion of it, kind of resembling an upside down tree. You have a main trunk that branches out into smaller branches, that branches out into smaller branches, until it becomes sort of infinitely small and terminates at the leaves of a tree or in the alveoli for the lungs particularly. The tracheal bronchial tree carries air into the lungs and extends from the larynx to the mainstem bronchus. So the upper portion, the very most upper portion of the airway, as air leaves the hypopharynx, the oropharynx, and the nasopharynx. The bronchi are the main stem branches, or the main stem bronchi, branch into the lobes of lung and then move into more tertiary segments, or tertiary bronchi, and then subsegmental bronchi, and then ultimately bronchioles. And if you look at the image on the screen here, you can see where the trachea is at the top of the airway. It moves down through the trachea where it divides between the left and right mainstem bronchi. That division point is known as the carina. Interestingly enough, it's also the very last gag stimulation reflex in the human body. This becomes important when we talk about suctioning, as if you are suctioning an endotracheal tube using a suction tip catheter, we'll measure the length of that suction device so that not to pass too far into the bronchia and stimulate that carinal gag reflex. It divides then further from the left and right mainstem bronchi into the bronchioles, and then from the bronchioles, it moves into the alveolar tissue, which is the parenchymal portion of the lungs, or the functional tissue of the lungs. Some notes about the bronchioles: unlike the trachea, they don't have cilia. The trachea is lined with cilia to help sweep mucus up and out of the airway into the mouth and into the nose, or rather into the esophagus in the hypopharynx. It's known as the mucus elevator. But once we get into the bronchioles, There's no cilia. They don't have any protective mucus like the trachea does, or the left and right mainstem bronchus. They do have smooth muscle around the airway. This controls the diameter of those smaller airways through bronchial constriction or bronchial dilation. The alveoli, the small air sacs at the end of the airway, is where gas exchange occurs, and this is where we exchange carbon dioxide with oxygen. The alveoli are the terminal airways, and the alveolar branches include 16 to 24 in each of the bronchial trees. The entire surface of alveoli and terminal bronchioles are covered in capillaries, and helps facilitate the exchange of gases between the pulmonary system and the circulatory system. It's worth noting that the mediastinum, or the middle chest area in the thorax, doesn't just contain the lungs. And this will become important when we talk about pulmonary blood flow and when we talk about intrathoracic pressure as a byproduct of things like positive pressure ventilation. It consists of things like the heart, large blood vessels, large conducting airways, and other organs, including the lungs. If you note, the pleural cavity is actually lined with a membrane, and we call those membranes pleura. You have a visceral pleura, which is closest to the organ, and a parietal pleura, which is further away from the organ. And in between the two pleural layers, there is pleural fluid that helps reduce friction as the chest expands and contracts to allow motion and expansion of those chest walls. Pulmonary blood flows from the heart to the lungs via the pulmonary artery. The pulmonary arteries are the only arteries in the body that carry deoxygenated blood. The pulmonary arteries then branch into smaller vessels, ultimately branching into the capillaries where gas exchange takes place in the lungs. Carbon dioxide is offloaded, oxygen is onloaded, and they move back to the central circulatory system via the pulmonary veins, the only vein in the body carrying oxygenated blood, to be distributed via the heart to the rest of the circulatory system. Pulmonary capillaries can be very narrow and thus are subject to complications when we talk about perfusion disorders as they relate to pulmonary disorders. The circulatory component of the respiratory system, there's a couple of key components. Blood has to be continuously flowing into all of the areas. And if that blood is blocked, for example, by a large embolus, which we call a pulmonary emboli, this can block blood flow to the lungs and prevent gas exchange from occurring, as well as prevent oxygenation of the tissues in the lungs. Cardiovascular regulation is also driven by the respiratory system, or has a component to the respiratory system. If you'll remember, the pulmonary system and the cardiovascular system are intricately linked with one another. They both need each other to survive and function adequately. The heart changes will have significant pulmonary consequences, and likewise, significant pulmonary changes will have cardiac complications. The respiratory drive and effort changes based on the pH of cerebral spinal fluid, and that changes by the amount of gas exchange that's occurring in the lungs, the retention or elimination of carbon dioxide. So if the pulmonary system is not effectively exchanging gas with the circulatory system, the brain and the body start to disrupt and can't function efficiently and determine the adequate respiratory rate for that particular patient. Likewise, the heart requires a lot of oxygen. And if the heart fails to become oxygenated, cardiac output will be decreased, which will further cause more hypoxia of the cardiac tissue, which will circulate and cause more hypoperfusion and ultimately cardiac arrest. So the heart needs the lungs and the lungs need the heart, and they need to work together coherently and cohesively as a single unit to maintain homeostasis for normal life to exist and function. Cardiovascular regulation. There are various forms of heart failure that can be caused by pulmonary diseases. Things like fluid balance changes, or for example, a patient experiencing pulmonary edema where gas exchange can occur, or a patient experiencing significant fluid overload or fluid imbalance, creating high pulmonary pressures or low pulmonary pressures. Conditions, cardiovascular conditions such as right ventricular hypertrophy, which sounds like a lot of words there. And for those of you in paramedic school and AEMT school, we will explore those terms a little more fully. But essentially, the heart becomes large and floppy. And as it becomes large and floppy or oversized, it becomes less efficient. And if the right side of the heart is less efficient, it can't adequately push blood into the pulmonary system, thus resulting in reduced oxygenation capacity. The same thing with the left side. If patient is experiencing left ventricular hypertrophy or a floppy left ventricle, if you will, oxygenated blood can't be adequately distributed throughout the body. Let's talk briefly about the mechanism for respiratory control. As I mentioned previously, the Respiratory Control Center relies heavily on the pH of cerebral spinal fluid, driven predominantly by the retention or elimination of carbon dioxide. That Respiratory Control Center ultimately controls the diaphragm and the intercostal muscles to expand and contract to move air into and out of the lungs. The normal process of ventilation is negative pressure ventilation. This means that at rest, if you let all of the air out of your chest and you rest, the diaphragm during inspiration will contract, making the volume of space larger in the chest, as you can see on the left side of the image here. That larger volume of space reduces the pressure inside the intrathoracic cavity, and air moves from the area of high concentration, the world around you, into that lower pressure area in the lungs. That's where air comes into the chest. And during expiration or exhalation, that diaphragm relaxes and moves upward back towards the superior portion of the body. That increases the pressure in the lungs, and air is expelled from that area of high pressure in the chest cavity, area of low pressure outside. Here's another image that shows that example. The thorax being airtight. As the diaphragm contracts, the volume gets larger and air is sucked into that space. During exhalation, the diaphragm relaxes and moves upward. That increases the pressure in the lungs, and air subsequently moves outwards. We calculate the amount of volume a patient is ventilating by a term known as minute volume. Minute volume is the respiratory rate times the tidal volume, or the amount of air, respiratory rate, the number of times a patient is breathing every minute. We're really looking for an average adult minute volume of somewhere of 5 to 6 liters per minute, or roughly 500 milliliters of tidal volume at a rate of 10 to 12 times per minute. Some injuries and complications can prevent the expansion of the lungs and thus prevent ventilation. Traumatic openings exposing the thoracic cavity to the outside world mean that they can't maintain pressure, and when the diaphragm flattens, not only will air move into the trachea, but air will also move into and out of that opening. When air is moving into and out of that opening, that's known as a sucking chest wound, and we'll talk about how to address that in the trauma chapters. Other body systems can impact the respiratory center. For example, renal status can play a role in controlling fluid balance and acid-base balance, which can certainly impact a patient's respiratory status. And then there may be other factors that prevent or disrupt oxygen delivery to the body tissues that we'll also discuss in some later chapters.